Good afternoon, everyone. Today I'm going to present a case on role of conservative therapy in ocular trauma case. So ocular trauma accounts for about 5% of all blindness cases globally, and it is classified according to the Birmingham Eye Trauma Terminology System, where if there is any breach in the eye wall that consists of the sclera and the cornea, it is known as open globe injury. If no, it is known as closed globe injury. In closed globe injury, again, there can be uh, contusion where there is no direct trauma, but due to indirect forces the injury occurs, and if there is any partial thickness injury, that consists of lamellar laceration. In open globe injury, if there is a injury with blunt trauma, then it is known as rupture. In laceration, there is injury with pointed object. If Again, it can be divided into penetrating, perforating, and intraocular foreign body. So my case is a 23-year-old male who presented to the emergency with injury with the blunt end of the nail. He was a carpenter by profession, and it had hit him in the eye in a projectile fashion. So patient was complaining of diminution of vision in that eye with redness, pain, and foreign body sensation since the time of injury. On ocular examination in right eye, everything starting from visual acuity to fundus was within normal limit. In left eye, he had a visual acuity of hand movement positive and a small conjunctival tear adjacent to the limbus with surrounding congestion, and grade 3 hyphema with traumatic mydriasis. We could not get any view of the fundus because of the hyphema, and IOP was borderline low, that is 10 mmHg as compared to 18 mmHg in right eye, and the cause for low IOP was thought to be due to ciliary, which was presumed to be due to ciliary shutdown. So according to the ocular trauma score, our case comes to have an ocular trauma score of 3. Patient was, a CT scan and USG B scan was done, which was within normal limits. So a diagnosis of left eye conjunctival tear with grade 3 hyphema and traumatic mydriasis was made. And patient was started on oral steroids, antacid, antibiotic, vitamin C, and topical steroid antibiotic, cycloplegic, and I was advised propped up position. At follow-up at 1 week, the visual acuity improved to 636, improving to 618 parts, and IOP also improved to 13 mmHg with resolving hyphema. On clearing of the hyphema, we could see a choroidal rupture in the left eye. So what was unique in my case was hidden ophthalmological finding with spontaneous resolution of hyphema and restoration of a reasonable visual acuity within 1 week only. Whereas according to the ocular trauma score, the 6-month probability of getting a 636 vision was only 28%. We saw similar improvement in visual acuity in 1 week. So that clinically implies that conservative management also plays an important role in ocular trauma cases, and there should be proper selection of those candidates based on the severity, presentation, and ancillary tests. These are my references, and coming to my take-home message, ocular trauma management case varies from case to case, and it requires careful decision-making between conservative and interventional approaches. Thank you.
Only one question, that if you are faced with a vitreous hemorrhage case and you are not able to visualize the macula, how do you come to know that there is a subretinal bleed or not? If there is a submacular hemorrhage, will you like to intervene early or not?
Should be, sir.
So the ideal timing which has been given is 10 days. So if you are having a vitreous hemorrhage which is precluding you to see the macula in 10 days, it is a wise option to intervene.
Okay, sir.
We can have the next